So dementia is multiple diseases that affect cognitive domains and are associated with a loss in function. Dementia is actually affecting over 55 million people worldwide. It's the third cause of death in Europe and North America. And in 2023, 170,000 Quebecers lived with dementia. And this figure is going to increase due to the aging of the population. And actually, we also know that there is an underdiagnosis of the dementia. So actually, the numbers might be even higher. Next slide. So the COVID pandemic did dramatically impact persons living with dementia. First, they had an unprecedented disruption to the care they usually receive. They had to stay at home. They had to physically distance from their usual caregivers, formal or informal. It was especially challenging to remember the public health measures. And for the care partner, that the burden did especially increase also. They had limited access to health services and resources. Many programs actually closed. Home care services, either patients or persons did not want people to come to their house in fear of the infection, or actually staff and health workers were redirected to other hotspots of the system. Their programs did close. There were informal directives not to transfer persons from long-term care facilities to the hospital in fear of spreading infections, and many community resources did close. Thus, persons with dementia actually have been disproportionately affected by the COVID-19. The most common comorbidity associated with death due to COVID in Canada was actually dementia. And 36% of all COVID deaths actually had dementia in 2020. And they were especially affected because of their physical vulnerability to diseases, but also because of all the measures. And actually, they presented very atypical symptoms of COVID that led sometimes to underdiagnosis. They presented with delirium, disruptive behaviors, loss of appetite, or even fall. We did publish an article at the Montreal General Hospital showing that actually fall was one of the clinical presentation of COVID. And as you know, like I have never heard during the initial phases, you need to do a COVID test to a faller. But actually we should have, and we are actually now. So it was really in the beginning of the pandemic that we designed the project. And what we thought was that we wanted to combine the power of numbers to the power of stories in order to cross-fertilize our study, to be able to share, to give numbers to the decision makers, to the Ministry of Health, with who we are very closely collaborating, as well as the Alzheimer's Society, as well as persons living with dementia, their care partner, their clinician, managers. And we wanted to give facts, figures, but also stories explaining the facts. So we did conduct a mixed method study, including quantitative study, where we generate numbers, and a qualitative study where we generate stories. Our first objective was to measure the impact of the pandemic on the health and social service use and mortality of persons living with dementia, both in the community and in long-term facilities. And our second objective was to understand the needs, behaviors, and experiences of persons living with dementia and their care partners towards health and social services. Throughout this objective, we were engaging persons with dementia, their care partner, decision makers, and clinicians, including the Quebec Ministry of Health. And the third phase was to to integrate resources of both phases of both objectives, and to produce evidence-based recommendations with patient partners, with care partners, clinician managers, and decision makers, as well as community organization, derived from our data. So to try to generate recommendation on how to better tackle next waves of the pandemic, but also how to better provide care to this population in situation of vulnerability. And in this project, we are actually 4 provinces, so Quebec, Ontario, Alberta, and Saskatchewan. And today we are going to present you the data from Quebec.
We have seen a lot of disruption in the use of services during the pandemic. It's very sad, but the mortality was extremely high among persons living with dementia, both in the community and in long-term care homes in CHSLD. And we saw that the human rights of persons living with dementia and their caregivers were not fully respected during the COVID pandemic, and revealed some pre-existing problems in the healthcare system, even though some health and social care providers and services tried to adapt as much as they can to the disruption of the pandemic.
And getting back to mental health in older adults during COVID, there's no surprise for us. We all knew that, all these points that my colleagues speak on were just a way during COVID of highlight everything that was already a big challenge, especially for vulnerable populations, especially for people who were isolated, who were having mental health disorders, dementia, depression, and other comorbidities. So this was just a way that really struck on our face all the weaknesses of the system, and we were really faced to learn and adapt and do really very different things from the standpoint of clinicians, from research, community organizations. I was so happy, and I really, my love for my job increased so much when I start connecting with community partners. I think we have not sufficiently appreciated the work of community organizations, the way they are the ones putting the time, and many times is out of the heart. So many people are just there without making, any money, because sometimes funding, how scarce might become. But they are there putting day in and day out their hearts and all their experience and connecting people to services. And we were able to create this wonderful program in which I know many of the people present today were part of. So about the reality, my colleagues in the previous presentation did a wonderful job explaining what sort of problems were identified in the research. We all went through this same storm, but in very different boats, right? So we all experienced the stress. For some people, it was much harder, especially for people who were isolated, people who were in nursing homes or were having comorbidities, and the healthcare system was not capable of responding at that rate. So one of the things that we as clinicians and researchers thought of was in this jump to telehealth, right? And let me share with you that we were kind of a bit scared. It's is this going to really work, right? So we were facing our own stigma, right? We were thinking perhaps this is going to be too problematic to just show up with, tablets and computers and robots and sensors and try to figure out how to bring services, right? But I want to tell you that in a huge proportion, we were so wrong, okay? We were able to see that during the pandemic, we would develop these protocols to teach digital skills. I would be speaking with people in their 90s that have never interacted with a computer. And the key was, I will give it a try, right? So giving that step of, let's say, hope or faith and openness of you know, it might or might not work, but there's nothing to lose. Let's give it a try. That was I would say, the whole difference, right? Because I had people, you know, 40 or 50 years younger who said like, no, I am not good for that. You know, again, part of this internalized stigma that because of my age, I might or might not be able to do something or learn something, right? So we developed these protocols to teach digital skills to older adults. This was done over the phone, right? Very, very friendly. We had this huge group of volunteers who were teaching older adults over the phone how to get on internet, how to get on Zoom, how to open an email, and so on. So at some point, we were able to deliver virtual reality headsets and deliver behavioral interventions to virtual reality in the people's homes. You know, these were older adults living by themselves that were able to learn on their own, like this sort of little adventure, and get a full, you know, 2 months intervention for anxiety, for stress, and so on. So the key message is, if you open your mind, things can happen, right? You can get surprised. And also the other key point is, you know, we have always to be checking on our own biases. What is it that we are just thinking that might not be true?
The challenges that our organization faced. I'll remind you that it is from my perspective. I'm speaking, yes, as an employee of ECOL, but it is from my perspective working with seniors for so many years and what happened in that time frame. So obviously March 12th, 2020, we can't forget that date. It was ECOL's last day of activities. After the initial shock, we began processing the immediate needs of our community. We divided up lists of names, especially those most vulnerable who had no internet, and phone calls were made to ensure that the basic needs were being met, ensuring all had enough food, medication, if they had family or neighbors who could help them out, and reminding them of hygiene protocol and physical distancing. In the beginning, that was difficult for seniors to understand, that they had to stay away and stay back, and it was a whole learning curve. In those early days, my job changed from activity coordinator to an outreach worker and communications officer. The staff basically had to reinvent ourselves. ECOL reached out to other community organizations to see what they were doing. We partnered with some and started doing grocery deliveries. But the major challenge was how seniors would pay for the groceries. We weren't equipped for Interact payment. Stores did not want cash. And many of our seniors did not use online banking or even have a credit card. So we accepted checks and money in Ziploc bags. Eventually, we organized a theme series of gift bag and meal deliveries ourselves to our most isolated seniors. Though many of our older senior volunteers stopped volunteering, younger members in our community who were off work at that time, stepped in and helped with the meal deliveries. Unfortunately, volunteerism in our organization has not returned to the pre-pandemic numbers. I must mention the importance of our senior outreach worker, Jocelyn, who went over and above her job description of supporting seniors in their homes. She hunted down and distributed PPE. She sat outside seniors' homes in all kinds of weather to chat through windows and doors, brought and delivered groceries. She supported family members who cannot visit their loved ones, who were isolated in their homes and in long-term care. She helped us with the navigation of technology and accessing, printing, and plastifying their Vaccine passports. When I asked Jocelyn what was the most difficult part, she said, watching her elderly clients deteriorate before her eyes. It still gets me. So she shared a quote from one of her clients, and it hits home. At my age, I only have a few years left, and they are being wasted away. Two of those major challenges, especially in Lanaudière North, was the lack of internet access and knowledge of technology. I speak not only for our seniors, but for ourselves included. There was a mad rush to hook up and educate ourselves with Zoom, live streaming, and recording equipment. The biggest feat was, number one, convincing our seniors to join us online. Number two, teaching them how, and then setting up a tablet lending program and providing support for the inevitable issues that did arise and still arise to this day. Extra costs were incurred for staff training, live streaming platforms, camera and recording equipment, and the amount of time it took to complete simple tasks due to the long lineups as a result of COVID protocols.
So here's a lot of reading, but you don't have to read it all, or you can just listen to me. It's up to you. I just wanted to outline the areas that we were affected immediately. And as I said, the previous presentation outlined very much the same thing. In March, all our in-person programs were canceled. We didn't have anything virtually, and all our staff were reduced. So we had to look at just having the main staff around, which also affected services. That everyone was told a 2-week closure. The 2-week closure quickly became 2 years. The seniors were cut off from socializing with their friends and families, especially those who were 70 and over, as they were not allowed to leave homes at all. And we saw a lot of people with a lot of anxiety and depression. We had to develop access to virtual programs and support because people were missing that contact. And again, all our staff had to go from knowing nothing with virtual, and none of our members or our volunteers, to only providing programs virtually over our spring summer 2020. Our own online programs, we only had online programs, and everybody was working from home, which was, again, was very new. That was in the program department. In the social services, again, the seniors were not permitted to leave, and their requests for services increased as a result. They didn't have any access to groceries. You'll see in the other one that we pivoted to allow them to have access to them, because a lot of our volunteers were 70 and over. And as a result, those volunteers were not allowed to leave their homes, and we had to find new volunteers to deliver our meals. A lot of it was flexibility, and you'll see that along for the next slide as well, that we had to maintain a very flexible environment. Jobs that were once those of staff or volunteers, we took on multiple jobs. So everywhere in all the departments, we saw something common. We had fear of COVID, isolation at home and curfews leading to depression and social stigmatization. People were unable to grieve as per cultural norms. So the Jewish religion, we have a funeral and then we sit Shiva, where people come to your house or to the house of the person who passed away, and you usually sit with them and you talk about the person, and it's a grieving period of 7 days. We were unable to do this, and that really affected a lot of people, the way that they were able to grieve or not grieve, or even go to visit people in the hospital. I had staff that could not go see their dying family members because they were only allowed to have one representative to go into the hospital. That took a big toll. So not only were we supporting our members, we were supporting our staff as well. So in the program department, our virtual library, one of the things we did was we opened it up to everyone. Everybody in the whole world could come to our virtual library, and we tried to promote that a lot with the marketing department. So people would come and it was free for everybody. Right now, we went back to it's being free for members, which membership's only like $30 a year. But we also have access to it through other programs such as Comings to Community or Comings to You, where we have programs, organizations, especially those who might be on the outskirts and are having problems finding programmers or specialists. We have prepared programs that they could have a group of people and watch it around a TV. So we did that as well during the pandemic. We needed a lot of support for people to get onto the virtual. So for the first, all throughout spring and summer, all our programs were also free virtually. And then in the fall, we started to charge for access to our programs. And that gave the staff time and the members time to get used to being virtual. There also was extra costs for laptops, for example. At the beginning of the pandemic, we had only 6 laptops for the whole agency, and we needed 90. So we had to quickly turn around, get grants, get money, find money, and get laptops for 90 people, which it was quite a demand.
This question brought to me today is, how did the pandemic impact our service delivery? So it starts with the staff. The fear and panic in the staff was so intense. The caregivers, they almost shut down emotionally. One of the things Brenda said, which was very true for us, is that as much as we had to take care of our clients, I have to admit the most powerful thing I had to take care of was my staff. I found that managing their panic and their fear was so much greater than the clients. So many of the workers, they left the workforce due to this fear and panic. They wanted to be protected. They wanted to protect their families from infection. And of course, they wanted to protect the clients. Going home, being with the children, going back to the clients, it was like a vicious circle. And the care team just really tried to pull away from leaving their homes just like everybody else did. Then, of course, there were the school closures and no childcare. So that within itself just made us have more and more staff pull back from working. Then we had the transportation issue. So the caregivers that would work, the caregivers that felt that they could manage this and they weren't in panic and they wanted to go to work, then you had the issue of them fearing being on public transportation. And then the ones that would go on public transportation, you had the clients that wouldn't accept them because they were on public transportation. So there was really no solution. And like everybody else, we were scrambling to figure out, how were we going to take care of people? Then we had the clients that needed 24/7. And that's when there were no choices. They needed 24/7, whether it have been to cognitive challenges or physical limitations. They had to have someone around the clock. So that's where we had to be extremely creative. And what had happened was, so the clients that had the financial means to implement care in their home to benefit themselves and the care team and put them all in a safe place and a safe environment, that worked well for those individuals because they had the financial means to make that happen. And it turned out in many cases to be actually a very beautiful thing to watch, because some caregivers actually moved in with clients. You would put in 2 or 3 in a home and we locked the doors. And it turned out to be beautiful experiences because they learned different cultures, they learned different cooking, they learned to communicate with different ethnicities, individuals. Like it turned out to be really, really a positive thing in those situations. But of course, the cases where people needed a few hours of service, they were lost, they were isolated, and it's like everybody else said, it just wasn't a good situation. So our clients at home were scared, they were isolated, they were lonely, and we just had to find creative ways like everybody else to make things happen.
One of my responsibilities, of course, as pastor was to make sure that in my parishes, when we were allowed to open, that we opened safely. And one of the great things, and somebody touched on this earlier on, was we experienced a growth actually in volunteers in our parishes. Some younger people in particular stepped forward because they realized the seniors who often do these volunteer roles weren't able to operate or were afraid to come to church, whatever. So when we were allowed to open, we had volunteers who were new. So we actually drew some new volunteers during that time. I wanted to speak really about grief and mourning and the experience of grief and mourning during the pandemic. One of the things that really struck me straight away was that families were prevented from being with the sick and dying. And it was very painful, very painful. Families reached out to me often to talk about how they felt. And of course, that huge sense of isolation and being separated from those they loved was traumatic. That word was used earlier today as well. It was traumatic. Husbands, wives, fathers, and mothers died without the presence of their family members. It seems incredible now to look back on it. And somebody else used this word, it was surreal. It really was a surreal experience. As a priest, of course, I couldn't visit at certain times the dying in nursing homes or hospitals to give the sacrament of the sick, which in the Catholic tradition is very important. Some people still refer to it as the last rites. And that was difficult for me. I felt very frustrated not being able to go into those situations. And also being contacted by families who wanted their loved ones to receive the sacrament of the sick or anointing of the sick, or even to receive some words of comfort or prayer from their minister. It was really difficult when I had to tell them I could not go into those situations. I was not permitted to enter the hospital at certain times. And so, again, it was really difficult for people to accept that was the level of restriction that we were living under. And that again, there was some anger, people express anger towards me. Why can't you go? And then towards the government, towards health authorities. So again, there was a little bit of anger around certain of the restrictions. For me too, as a priest, the way we administer the last rites or the sacrament of the sick to the dying is a very physical thing. It involves touch. So again, even when we were allowed to go to do that, we weren't allowed to physically touch the person, or we had to touch them wearing gloves. And again, the expression of faith or sympathy and the sacramental expression in the Catholic tradition is very, very physical. We touch, we have a healing touch, a comforting touch, and we were not allowed to do that, neither priest nor family member at times. So again, those points of human contact were stripped away from us. One of the things that I found the most strange was, again, in that context, praying down the telephone, where a nurse was holding a telephone against someone who was dying's ear, and I was saying the prayers for the dying down the phone to this unresponsive person, a nurse holding the phone.
We did see that there was a huge impact on those more vulnerable people, especially those who had adapted needs. And adapted needs, you could even be something just post surgery, or you could have had a stroke or a heart attack. We also support people who have Parkinson's, or people who have aphasia. So we do really support a lot of these people, and the more vulnerable people were the ones that really were affected by the pandemic a lot. Next slide, please. So the impact of COVID-19 for seniors, these are some of the lasting impacts that we saw. Increased anxiety, depression, fear, and anger. So why do I say that? Well, if we look at it, one of the anxieties that people see is, COVID hasn't gone away yet, as I can attest to that today myself. And also it changes things. We were supposed to have another speaker today. Something happened. I mean, things change all the time because we're still being affected by COVID every day. But people who are older, and especially those who live in senior centers, have a fear again. Is it going to happen again? Are my rights going to be taken away? Am I going to be put into a lockdown, be isolated from my family, be isolated from my friends, literally be kept in prison? And this is a really huge fear of people. It was horrendous. It was being in isolation. They weren't allowed to talk to anybody outside of their rooms. They can only talk to people on the phone. A lot of people at the beginning of the pandemic did not have any virtual access to technology. So, slowly, yes, we were able to get people their iPhones, their tablets. But initially, most of these people did not have anything like that. And then you have to also remember the people who have some dementia, even if it's, they've lost some cognitive abilities and they weren't able to understand how to use this technology. So it was very isolating. So they have this fear. And the anger again, is because they felt that they were treated as second-class citizens. Why them and not other people? They said it was for their own safety, but they were angry that they were not given the choice. It was just something that was put onto them. They were not given the choice of whether or not they wanted to move into another place or if they wanted to go somewhere else. They were just like, this is it, you're in lockdown, that's it, that's all. And one of the things that we found is a lot of the places where there's long-term care or even just senior residences, one of the major impacts that we're still seeing now is that they're not having the same kind of recreational activities that they had before the pandemic. A lot of people moved to these senior residences because everything was provided for them. If they wanted to have a meal, the meals were available. If they wanted to have laundry, laundry was available. If they wanted to have entertainment and exercise in their own building, it was there. After the pandemic, these people were not getting it during the pandemic. And even now, we found that they were not receiving people going into the building. It's very hard to find people to go into buildings to do exercises and programs for the senior residences. We developed a program. It's not a selling thing, but I think it's so important that you know about this, that we go into people residences. We will provide services for senior residences who can't find art therapists, who can't find exercise therapists, or any kind of other recreational activities. We go in and there are people that are telling us we have not had any activities for 3 years. 3 years? So what have you been doing this whole time? They go, nothing. We just sit around and talk to each other. Extremely, extremely sad. We've had people we've seen both with us in our own building and in these senior residences that they're not able, they lost a lot of their mobility. They lost a lot of even their functional mobility as their fine motor coordination, their proprioceptive skills, being able to just, move their muscles. And we found that even within just a short period of time, by doing the right kind of exercises, they regained that ability.
Over the years, like many other organizations across the province, we have wellness centers. So this is a programming that permits us to do outreach activities with our senior communities. And for us in the North Shore, we have two wellness centers focused into the Sept-Îles community and the Baie-Comeau community, where we see a large demographic of English-speaking seniors, and many of them unilingual. So the level of bilingualism in some communities are quite low, and some seniors really do not speak French. We're about, in Baie-Comeau, we're 1.1% of the overall population. In Sept-Îles, we're about 3.8%. So it just shows you that predominantly it's the French-speaking communities. So before I even go and talk about, the lessons learned and moving forward. What Brenda had mentioned earlier, I was shaking my head and say, yes, I've seen this too. I've seen this too. And, the Cumming Center is in Montreal, and we're totally east from Montreal, and we're seeing this into the regions. Very common, similar traits that we've seen that the impact of COVID has done. But just to go into an immediate impact that COVID had on seniors during COVID. So this is what we experienced. First of all, number one, there was a lack of information in English from the health and social services. Just a lack of information. The bi-weekly, weekly, or even monthly updates that came through the public health sector, because we were all color-coded and we had different measures to put in place. And this was all trickled down by the public health of our regional CIS. And there was pretty much nothing in English, because the Côte-Nord region, the region that we're in, we have, just going back to the access program, we have indicated institutions, meaning to say that you don't have to have things in English. There's only one area that is a designated institution, which would be the Lower North Shore. So by law, they had to have everything bilingual. So in the Côte-Nord, in Baie-Comeau, Sept-Îles, Port-Cartier, no, we didn't get anything in English, and it was us that was doing a lot of the translation. So that was an immediate impact that had on seniors. It's just being aware of what measures were in place, what should I do, what can't I do, and then just the challenges of finding that. So what happened is we did some research, and what we found is that a lot of the information was being channeled through the PASOC organizations, which is the Programme Soutien Organismes Communautaires. And these were the organizations were doing direct delivery in community health and social services. So a lot of the information, or all of the information, was being funneled through their regional umbrella group, which is called the TROC, the Table Regional Organismes Communautaires. And so we had to reach out to them. We had to tell them who we are, what we're doing, and all this. And we wanted to be part of that email string. So after a while, I did get onto the email string so we can have the information. We had, because there was no services out there for the English-speaking seniors in our community, we were known to be the go-to organization to help out seniors. So we've reached out to seniors that we didn't even know existed. That okay, so our membership or our listing did increase, and that was something positive that I would say that the COVID had done, is because it made us more aware of other seniors that are out there, and also made us more aware of the needs that these seniors had. So we had an increased list of shut-ins and respite care. We are fortunate to have a long-lasting program through Appui that we do respite care for clients that have dementia or Alzheimer's or Parkinson's. So that list increased a slight bit, so we were more aware. So we were fortunate to receive a little bit more funding in order to do more hours for that. And because we were the go-to organization, we had to be a little bit innovative and try to keep the wellness activities going. So we went to the virtual mode, and we did online games, bingos, social teas in the after hours, trivia, all these fun things, because what the seniors wanted, they just wanted to socialize, they wanted to interact, they wanted to talk to each other. But that being said, we did have some seniors that were not so less technical savvy around using a iPad or a tablet. So we were fortunate to get some iPads, and we were fortunate to have some volunteers in the community that would go and just do a little troubleshoot, set up their Zoom so they'd be able to interact. Also, we saw an increasing need of around technical support for seniors to be able to do the online registrations for vaccinations. We had seniors that didn't know how to navigate the CIS site, didn't know how to go about in booking their vaccinations. So we did a lot of outreach and support around there.
What is this new reality? And I love that Ruth used this term of attracting quotes and retaining healthcare professionals. The truth is, we're incredibly attracted as pathologic empaths to the idea of helping others, okay? That's not the biggest problem. The biggest problem is the burnout. The fact that it happened before COVID, but with the gaslighting and broken systems and fragmentation that you heard a little bit about, it got even worse. The data that I'm going to be talking about in the next couple of slides, you'll have to excuse me being a bit of a nerd. I just want to give you my references, was from the United States Surgeon General, Dr. Vivek Murthy, in a publication in New England Journal last year, where basically he discusses health worker burnout and well-being. So I'm going to try to stick to the salience to leave us time for questions, feedback, criticism. But basically, more than half of health workers report symptoms of burnout. And most of us are dealing with insomnia, depression, anxiety, post-traumatic stress, and other mental health challenges. We can go to the next slide. And I thought this point by Dr. Murthy was phenomenal, which is that burnout, or sometimes it's called moral injury, which I really appreciate. Because burnout, it sounds pretty simple. You're exhausted, you're done. But moral injury on a higher level really addresses the root cause, which is, I love loving my patients. But if the system is so broken that I cannot love my patients, it hurts me on a moral level. It is wrong that I don't have X to take care of my patients. And that feeling, that disconnect, where one thing is expected of us, but our reality is very different, creates a moral injury. And that is very much linked to burnout. And I think that while I don't have it written here, I find it interesting that that's a systemic problem. So this point that burnout manifests in individuals, but it's fundamentally rooted in the system pathology, is an excellent example of the fact that there's escalating workloads, inadequate support, administrative burdens, and chronic underinvestment. It's not just about working longer hours. It's about the fact that our mission to serve and the resources we're given and support we are provided don't allow us to do our jobs the way we want to. I think it's important that we recognize that depression can manifest as anxiety and is dramatically worsened by isolation, okay? And when we talk about these things, God forbid, suicide is one of the potential outcomes that has gone up 4 times, okay, in terms of suicidal ideation, thoughts about suicide, dark thoughts. You can phrase this many different ways, but in Quebec, over the age of 65, we have had 4 times the amount of dark thoughts. I thought it was interesting that while the general population of seniors, we are at about almost 6%. In Quebec, it's closer to 8%. Sorry, in Montreal, it's closer to 8%. In the interest of time, I won't get into possibly why, but higher density doesn't mean more connection, is my theory. And we know that with age, depression doesn't show the same as it does in younger individuals with sadness and loss of desire. It can manifest in aches and pains, problems sleeping, more confusion, more irritability. And these are signs that someone might just say, it's just old age. No, not necessarily. So we can't be so dismissive. What this first point says is that public health measures that limit access really need to consider the impact on individuals in long-term care. All long-term care facilities must have adequate training, staffing, and resources to address mental health during COVID and other outbreaks. And measures of mental health and quality of life in long-term care must be systematically evaluated and have strategies to understand and remediate the adverse outcomes. What's the problem with all of these fancy, wonderful position statements? You can't expect a third or half of the healthcare workers to do 200% of the healthcare workers' jobs. It's just not going to happen. And the outcomes you're going to have are what we saw in long-term care. So it's okay to expect these things, but you need to provide our system with the tools to do it.
I was fascinated by what Dr. Kay said about the social determinants of health, because it's something that I talk about every single day. And that is very simply that if someone does not have adequate shelter and security of healthy food, that we know categorically, empirically, that they're going to suffer from suboptimal health outcomes. And so the work that we do at Welcome Hall Mission and have done for 133 years here is all around making sure that those social determinants of health can be improved for people who are extremely vulnerable, people who are either experiencing homelessness or who are struggling to make ends meet. Our free grocery stores, for example, serve 10,000 people every month. These are people who are housed, but who struggle at the end of the month to figure out, should I pay the rent or do I have enough money left to buy groceries? If you look at the very first photograph that I'll put up here, the doctor talked about moral injury as a function of another way to say burnout. And when we look at what's going on out in the big bad world, what's happening on the streets, what do we see? Well, we see a lot of people who are suffering from challenges. The concern, the challenge of homelessness that we face at Welcome Hall Mission is much more complex than it used to be. And, how do I relate this to people who are concerned about the well-being of seniors? Well, we know from statistical data that the age of the first experience of homelessness is actually going up. Used to be that, generally speaking, someone's first experience of homelessness happened in their late teens to late 20s. And then there was this pattern that repeated itself. We're seeing more and more people now who have their first experience of homelessness in their 50s. And that's a concern. It's a concern for a variety of reasons that I'm not going to elaborate on right now. But Dr. Kay touched on the fact that seniors are people who have contributed greatly to society. And to me, it's a horrible shame when we get to the point where we're in our 50s or 60s or 70s or greater, and we run into a challenge whereby society is not able to properly have the structures in place where we can get the care that we need. The other thing that we see, and you'll see it in the next slide, is challenges related to mental health, particularly among the young. But Dr. Kay touched on it quite eloquently to say that it's also among older people, and perhaps far more prevalent than what we see. Because the next slide that I have there, it shows a senior, and we know that isolation was a factor well before the pandemic, and that there are a lot of challenges related to isolation, mental health being one of them, but there's a lot of them. And I love what Dr. Kay said, that population density does not translate necessarily into better personal and human connections. And we've certainly seen that in Montreal. So, During the pandemic, I would say before the pandemic, our free grocery stores did not deliver. So if you wanted to get free grocery stores at Welcome Hall, or get free groceries at Welcome Hall Mission, you had to come physically and take your shopping cart, go around, select your products, and have the experience of shopping. But of course, during the pandemic, we had people who were immunocompromised, etc. And so we decided we would start delivering to those people, many of whom were seniors. And one of the discoveries that we made, which will not shock any of you, is that a lot of seniors, the only human being they saw was us. When we delivered our groceries, and then the next week when we came back again. And it caused us to start a new program, which Ruth alluded to, where we're serving seniors who are getting free groceries from us, but that's not all they're getting. We're helping them reconnect to a network of care, whether it's social services or whether it's making sure that they're hooked into the medical system, the network of medical care, the hospital system, and so on, going to their appointments and so on. So that's a very important thing, and we think it's critical. And you'll see on the bottom of some of these slides, loger, nourrir, aimer. Those are our three buzzwords here at the mission: shelter, food, love. And for us, it's just a reminder of our key drivers, sort of the reason why we do what we do, because we believe that everyone should have access to a roof over their heads in Canada. There's no reason in the world why all of us as Canadians shouldn't have some place to call home that's suitable. And nourrir, or food, is all about getting access to healthy food. Canada produces more than enough food to feed everybody several times over, yet 35% of Montrealers suffer from food insecurity, and that just doesn't make sense to us. And the last one, which is about love, is really about being connected to a community of care. So back to the social determinants of health. If I, as an individual, have a roof over my head, if I have access to healthy food, and if I'm surrounded by some people who care about me, maybe not a lot, but at least some, there's a good chance that I'll have good health outcomes. And we know that the opposite is also true.